How to do lung biopsy and aspirate pleural fluid in the same sitting. First, check previous CT scan reports and other findings and verify with the prescription or medical advice. After verifying all details, do a check CT scan to assess the feasibility of the biopsy and aspiration of fluid. In the present case, we can see there is accumulation of fluid in the right pleural space, as well as there is a solid mass in the upper right lobe. Now coming to the planning of the case, we can measure the distance of the lesion from the skin surface. This is the planning. Under CT scan guidance, we can measure the distance of the lesion and the accumulated fluid from the skin surface, and we are inserting the needles for confirmation of the needle position before injecting local anesthesia and aspiration of the fluid. And after confirmation, we are injecting the local anesthesia. Yes, the positions are confirmed. Now we can aspirate the fluid first. We have to aspirate the fluid before doing biopsies, because if we aspirate the fluid after biopsy, it can contain hemorrhagic material or blood. In that case, the color will be red. We can see the fluid is coming out. There is huge collection. We are collecting the fluid and transferring it to various types of tubes for cytological, biochemical and malignant cell studies and cell block preparation. After collection of the fluids, in the meantime, the local anesthesia will do its job, and the area of the biopsy will be desensitized, so the biopsy will be very easy. Doing biopsy, collection of the tissue will be easy. After collection of the fluid, close that area with skin adhesive, and now we are starting with the biopsy. As per CT scan, we can measure the distance of the lesion from the skin surface, and we can see in this gun there are markings on the gun. Each marking is 1 centimeter. So in this case, it was 5 centimeter away, deep from the skin surface, and there is obstacle from rib. There are many ribs, so bony obstacles are there. So we have to manipulate the path of the gun little bit, and we have to use the same track, always same track. The insertion of the local anesthesia, that area we have to use every time. We have to use that skin prick site, and we can see the tissues are coming gray whitish color and glistening with, because there is fluid also. There is no blood in this case, no hemorrhage. We can see that tissue length is larger than the notch of the gun, because we know that the lung tissue is spongy. Whenever it comes out, it becomes expanded. So we take multiple tissues, at least 6 to 8 tissue cores, and if there is necrotic part, we try to collect tissues from the surrounding areas, including normal some portion of the normal lung, so that some viable tumor at least should be there. In the meantime, we talk to the patient if she or he is feeling any discomfort. In this case, she is saying no, nothing is happening, no problem. So we can take more passes, more tissues. We are collecting about 10 tissue cores for various studies. We can you can check. There are many tests like immunohistochemistry, EGFR test, Ross, etc., molecular test. So we are collecting the tissues, and in the same time we assess the content, tumor content on a glass slide. Through the naked eyes we can see the cellularity on the glass slides, and after everything is done, tissue collection is completed, we close the needle prick side of the wound with skin adhesive and ask the patient herself to press that side. And this is the check CT scan. After doing the biopsy and aspiration of fluid, we have to check if there is any pneumothorax or hematoma or any problem, any injury to vessels. We can see there is reduction in the content, fluid content, and there are marking for the collection of tissue cores. There are vacant areas on the solid areas, and everything is okay, so we discharge the patient.